everyone, I am Ashish Singh from Vedic Dental College and today we will be discussing about habit breaking appliances. Now, what is a habit? Habit is a fixed or constant practice established by frequent repetition. This was given by Dorland. Now, what are the reasons for development of habit? It can be instinct, insufficient outlet for energy, pain, discomfort or insecurity, abnormal physical size or parts, or limitation and imposition by parents or others. Examples include mouth breathing, tongue thrusting, lip sucking, thumb sucking, nail biting, bruxism, etc. Today, in this video, we will be discussing about 3 oral habit breaking appliances. They include oral screen, case-link tooth positioner and night guard. So let's discuss oral screen. Oral screen is also known as vestibular screen. It was given by Newell in year 1912. It is a functional appliance because it has no active elements designed to produce force. It produces its effect by redirecting the pressure of muscles and soft tissues like lips and cheeks. It is made up of thin acrylic sheets. Now, indications for oral screen are: it is given in cases of oral habits such as mouth breathing, tongue thrusting, lip biting and thumb sucking. It is given in the cases of mild proclination of maxillary anterior teeth. Contraindications of oral screen: in patients who have mouth breathing habit due to nasal obstruction. Such patients are referred to ENT surgeon. It is not given in the cases of correction of class 2 malocclusion. Uses of oral screen: used as both active and passive appliance. Used for correction of tongue thrusting, mouth breathing, thumb sucking and lip biting habits. Correction of flaccid hypotonic orofacial musculature. Counteract deficiency in lip posture and function. Correction of mild proclination of incisors. Advantages: simple and versatile appliance in early interceptive treatment. Oral screen establishes a better muscle balance between the tongue on the inside and buccinator mechanism on the outside. Corrects the faulty relationships of upper and lower lips to each other and near normal lip seal become possible. They contribute to the development of a proper functioning occlusion. Effective mechanism for reducing or eliminating hyperactive mentalis activity. Best suited to work with abnormal lip and tongue activity. Disadvantages of oral screen: it is not a complete mechanotherapy. It is only a phase 1 therapy for orthodontic problems. Now, let's learn about mechanism of action. The oral screen prevents the pressure from cheeks from acting on the dentition. Because of this, the tongue is free to exert its force. This causes passive expansion of the arches. The pressure from the lips is directed to the incisors. This causes lingual movement of the labial procline teeth. Retroglutination of maxillary incisors results. Lower jaw is moved forward if the appliance is fabricated in a protrusive bite. Hypotonic lips are activated. Tonicity of the lips is improved. Possible intrusion of maxillary incisors and differential eruption of molars. Adjustment of oral screen appliance. The appliance should be worn by the patient every night and during daytime when possible. Lip seal exercises should be done for about 30 to 40 minutes per day. Breathing holes should be gradually reduced in size. Padding with quick setting self-cure acrylic is done in areas where tooth contact is present. Now let's learn about modifications of oral screen. The first one is Hort's modification. Addition of a wire loop to the anterior aspect of the screen. Patient pulls the appliance forward by grasping the loop while simultaneously resisting the displacement of the oral screen with tightly held lips. Second, oral screen with breathing holes. Place breathing holes in the labial aspect of the oral screen. A button with a string attached is placed on the lingual aspect. Patient is instructed to perform exercises by pulling the string through the breathing hole. The holes may be gradually reduced in size as nasal breathing takes over. Third, double oral screen by cross. Useful in patients with abnormal tongue posture, tongue thrust. A lingual screen is attached to vestibular screen with two 0.9 mm wires that run through the bite in lateral incisor area. Fourth, oral screen used in open bite cases. The tongue is kept away from the dentition by an acrylic projection. Fifth, modification by Rehak. In this, a nipple is combined with the screen which projects out. The nipple has to be retained by the lips. Therefore, the natural sucking movements are used to increase the effect of the oral screen. The next appliance is night guard. It is also known as bite guard, occlusal guard, and occlusal splint. Mechanism of action. It protects the teeth by absorbing the forces and energy created during an impact, thus decreasing the likelihood of trauma to the oral cavity. They work by bite raising effect, that is, passive stretching of painful muscles. Indications. It is given in patients